We know 2 billion people worldwide suffer from micronutrient deficiencies.
About a third of the world population.
That's right. So we're talking over 1 billion people could benefit. The UltraRice project itself is a technology to improve the micronutrient deficiencies among rice-consuming populations in the developing world. The UltraRice grain can hold iron as well as other micronutrients, and so it's a really simple way to actually get micronutrients to the population that needs it.
We have assembled a team of nutrition scientists, product developers, and food engineers to develop an improved formulation for UltraRice. We are looking for a truly enduring and sustainable solution.
I'm now pleased to welcome and to introduce Mr. Robert Miller, Divisional Vice President, Research and Development of the Scientific and Medical Affairs components of the Abbott Nutrition Organization. Please welcome Mr. Miller.
So thank you, Congressman B. Ryder, the Chicago Council of Global Affairs, and particularly my time that I've been able to work with Lisa Moon, particularly when she told me her sense of humor of getting something in 5 minutes from me. So I thought that was really, truly a challenge. So what I want to do is I just want to briefly give you a sense of Abbott being a diversified healthcare company. So what is the nutrition industry doing in this context? So the challenge of malnutrition today is, as you've noticed and heard about, it could be this bowl that signifies the fact that that bowl is empty for this child. But what you've heard, again, even more so, is that bowl could be full, but it's not of the right nutrients. It could be in an approach where we're providing the wrong food, or maybe even at the wrong time. So our challenge in the nutrition healthcare industry is, how do we get the right nutrition at the right time to the right individual as we approach it? And I'd like to give you some examples of how we see that and how we're approaching it. So you've seen this number, $2.5 billion in the next 30 years as we bring on to that. But I want to point out is the fact that this is no different than it was 25 years ago, 30 years ago. We added $2.5 billion over the last 30 years. So whatever we've been doing, we certainly have been successful as we start seeing industry, government policy, NGOs have risen to the challenge. But did we really think about the fact of what does that challenge look like today? So what I would suggest is that it's not just the challenge of the number, but it's what will the face of malnutrition look like? And I want to show you some of those things that we're running into. For me, one of the most astounding statistics as you think about these numbers is that in 2006, there were more healthcare-related issues with overnutrition than malnutrition. So I think in some ways we're in a grand experiment about what is going to happen in those next 30 years that is really going to change the way that we approach this. So undoubtedly, we think of the assumptive face of malnutrition, as you see here, starvation, where people are living on $1.25 per day for everything that they have, every element that they need to do. And my colleague John Janaskal and Kathy Pickus last year talked to you about the work that we're doing with Partners in Health and in Haiti, where we created a sustainable approach in order to treat severe malnutrition. So that certainly is one of those, and it's something that we can't forget. But what I'd like to say today is that as we look at it, the issue has become more and more challenging in some ways. It's almost more insidious. It is now not just about the food, the calories, as we've heard about, but the right food, right nutrients on that plate. And so it's really, kind of a great, metaphor for that. And I know that most of us in the Midwest understand as we come out of a really rough winter, that what you put in there is very important because you could just end up with that plate empty again, as opposed to having the right mix to ensure that you've done what you can. So what we want to do is avoid that reoccurring. So, as I said, Abbott being a diversified healthcare company, what we're taking a look at, and as we talk with our healthcare providers across the globe, and I'll mention something about that in a minute, is that we're seeing the faces of malnutrition look quite different today than they would have been that 30 years ago. So if you start in the bottom left-hand corner, what we're talking about is disease-associated malnutrition. I'm going to talk a bit about that. As you go to the right then, counterclockwise, we start talking about just mildly overnutrition. What does that mean for a person as they may be going through any type of, in the intensive care unit, something happens, or on oncology? And then finally, the child there that's thinking about in school, what are they eating and when are they eating at the right time in order to some of the things that we talked about as elements of school. What I want to point out is that for us, and when we get into this, it's not just about the macro number and the faces of these individuals, but we need to work with the caregivers and we need to provide science behind that. So that's one of the key things as we look at that is first, we need the call to action that we're going to do something about it, but we have to have a shared understanding of the complexity. And that complexity, if you take a look at right now, we're first interested in the knowledge, shared understanding, and then clearly solutions that we're going to bring to that. So we have taken a leadership role in nutrition-related health economic outcomes research. So what does that mean? We are looking at disease-associated malnutrition. And when we have done that, and we've done this in China, in Europe, and in the US, you find staggering numbers. This is about specifically 66 billion in China that they are today related to nutrition. And in fact, we actually published with Science a magazine in order to provide the type of information on addressing malnutrition to improve global health. Because it's a matter of getting out the information as much as it is understanding it. So once we have done that, we have engaged the stakeholders in patients, payers, governments, and media to help us understand what can we do with this. Now, what's really stunning to me is something that I've been in the field for 30 years, and so that's got its good and its bad element of it. But in those 30 years, what we have seen is something that I think is quite disturbing. And that's the fact that in this disease-associated malnutrition, that in 1974, this was described by Dr. Butterworth at the University of Alabama, and it was the skeleton in the hospital closet. 30 to 50% of all patients coming into the hospital were malnourished. In 2011, a publication reviewing it again, it is currently at 30 to 50% are coming in malnourished. We have made no advances on that. And what's even more astounding is that it is true whether it's the US, Europe, or China. So what you have is you have an absolute epidemic of approaches that still plagues us today. So what we have done in this is we actually then went in and we looked at 10 million records over 10 years in the United States to understand, does nutrition actually make a difference in this? And we worked with Precision Health Economics and found out that if you take a look at the length of stay, there's a 21% reduction. That's in full 2 days when people are treated with nutrition, when they actually are screened and they do something about it. There's 22% reduction costs in the US. That's almost $5,000. And readmission rates are 7% less. So all of this has very economic benefits, but think about the practical when you have the face of the individual behind it. Now, what about this issue that we have of the obesity or overnutrition? Here's a body mass index, shows kind of the consequence. 17 is on the low end. In fact, it would be talked about malnourished. In the red, as you see, that's skeletal muscle. As we take a look at somebody that has that body mass that's going up to 25, that would be mildly obese, the yellow part of that is the fat in the inside, and then the blue is on the outside, subcutaneous fat. So when we talk about it, then your body mass index of 38, take a look at that. But what's astounding is the muscle mass of these three individuals is equal. Why is that relevant? When we start talking to physicians, When you're treating somebody for cancer, you're doing it by the drugs on body mass index. And yet their lean body mass, the mass that's actually working, is really the same. So what happens, or when you have somebody coming into your nursing home or hospital, how do you see that when you see somebody that looks actually quite reasonably well and plump? But it has nothing to do with the lean body mass, the mass that's actually working in that. So I've been very fortunate not only to work in this field, but on September 17th, I became a grandfather for the first time. And so it was great for me and even more exciting for my son. So Ezra Dennison Miller came in, and what I was really thankful for was the fact that he and my daughter-in-law had an opportunity of having great prenatal care. And so this was something that, in taking a look at that, how appreciative we are around that. But that's not true across the globe. We've heard about those types of things. Although 10% of all births in India are preterm, which is actually 12% in the United States. 30% of the total are low birth weight, compared to in the US, that's 6%. This is where undernutrition for maternal really makes a difference. So if my grandson Ezra is anything like I was, what you would have is he'd be looking off in space and unfocused during school. But the key part of that is we're finding out now is it's the right nutrition, because it may be more about his glycemic response and how his focus. But this is the science we need to do. And our current belief is it's not just the right balance of the nutrition, but we have to have that with parents and schools. And we have also created, with the University of Illinois, this Center for Nutrition Learning and Memory, in order to make sure that we're actually studying this and understanding what nutrients actually do make a difference. And is it glycemic, and when is that? So we can only hope that our children, as they're developing this, that the grand experiment we have with overnutrition and that for undernutrition doesn't lose, as I think the panelists said, the fact that it is really about the cognitive health, that what are we trying to do here? So I'm going to leave you with the fact that we are partners with PATH, and you're going to hear from David Fleming a little bit later about all of the work that they're doing on that. But what I want to say is that not only is it about getting the right nutrition, but it really is a fact of behind all of the people that we're working, it is both the scientists and the healthcare professionals, that face of the caregiver, that is particularly interested in working in and across all of these types of partnerships. So with that, I just want to say is that I think the face of malnutrition is changing rapidly, and it's going to be very profound. And these are the types of things that between industry, government, food, agriculture, and health is that we're really going to have to figure out how to work together. I, for one, though, am very optimistic, because when I think about the last 30 years and what we've been able to do, it's all within our ability to take action, as I call all of us to do, in all of those areas, whether undernutrition or overnutrition. Thank you very much.